team. We'll be ready and waiting for you. All right, here's what we've got. 27-year-old male involved in a head-on collision is coming in. Major impact of the chest to the steering wheel. Older car, no airbags. Medics diagnosed a right pneumothorax. They've needled his chest to relieve the pressure. And right now the patient has one IV and has gotten about 300 milliliters of fluid. He's on 100% oxygen by non-rebreather mask. His vital signs are heart rate 120, respiratory rate 36, blood pressure 102/74, pulse ox is 94%.
In this program, we will discuss chest tubes, including the rationale for their placement, as well as the procedure for their insertion and the equipment needed. In addition, nursing care of the patient before, during, and after the tube has been inserted will be discussed.
So before the patient gets here, let's set up the room and make sure we have the equipment for chest tube placement ready. ETA is 5 minutes and the surgeon should be here shortly.
A pneumothorax is serious. Why do the paramedics think the patient has one? I've read all about them, but I've never taken care of a patient with a pneumo before.
I remember those days all too well when a patient was coming in with something I'd never seen before. I'm proud of your honesty. That's a good thing. But just remember, today is your first day in ED, so you're just going to observe what goes on in the trauma bay. Now, about this patient, do you remember what a pneumothorax is?
Isn't that where you blow a lung?
Well, that is a bit simplistic, but basically yes. A pneumothorax occurs when air enters the pleural space and causes a partial or complete collapse of the lung. It can occur with trauma to the chest because of overaggressive bag valve mask respirations or ventilator settings being too high.
That shouldn't happen too much anymore, right? Because the vents have lungs and the pressure's too high. Well, I remember that from my last clinical rotation in the ICU. I was there just before I graduated a few months ago.
Now let's head over to the trauma bay. Hi, this is the trauma bay in the ED. We'll need a stat portable chest in about 5 minutes for a patient with a pneumothorax rolling in. See you then. Thanks.
To prepare for the patient's arrival, the nurses will get the monitor and pulse oximeter ready. Connect a non-rebreather mask to wall oxygen. Set up and test the suction system with the tubing at the correct length, and get out the chest tube kit and collection device.
Hi, Dr. Jones. Rescue 14 will be here any minute. We're getting supplies ready for the chest tube insertion. What size gloves do you wear?
Size 8. I just got the report. Looks like the paramedics did a good job managing the pneumothorax.
A pneumothorax is a medical emergency. Its diagnosis is made on clinical signs. Treatment is not deferred until the patient arrives in the hospital or has a chest x-ray. The priority of care for a patient with a pneumothorax is to quickly relieve the pressure within the chest cavity. This can be accomplished in the field or within a healthcare setting by decompressing the chest with a needle. To perform this procedure, the landmark site, which is the second intercostal space at the mid-clavicular line on the affected side, is located and cleaned using either povidone iodine or chlorhexidine scrub. A 14-gauge angio-cap is then inserted. A rush of air or whoosh sound should be heard immediately, indicating that pressure within the chest has been diminished. At that point, the catheter is secured in place.
I see you have all the equipment ready for the chest tube insertion. We'll be ready for the patient as soon as he rolls in.
Equipment on the tray would include sterile gloves and drapes, the surgical scrub, a scalpel, hemostats and clamps, syringes and needles, a local anesthetic, and suture material. Chest tubes come in a wide range of sizes to meet the needs of patients from premature neonates to large adults. Some tubes have a trocar to facilitate insertion. The tube to be placed is determined by two things: size of the patient and what needs to be removed. Draining of fluid or blood requires a larger tube than one used for the removal of air.
Dr. Jones has just finished his initial assessment and agrees that the patient needs a chest tube. Let's watch what's going on.
Mr. Magnuson, you need a chest tube. What that means is that we're going to make a small decision.
Now tell me, why is a chest tube used for managing a pneumothorax?
I know that air has entered the thoracic cavity, which disrupts the environment of negative pressure.
To understand what a pneumothorax is, you have to understand the physiology of the respiratory system. Normal breathing operates on the principle of negative pressure.
During inspiration, the diaphragm lowers and the outer intercostal muscles contract to increase the area within the thoracic cavity. This serves to make the pressure within the area lower than atmospheric pressure, forcing air from outside into the lungs. Once the air has entered the lungs, the diaphragm relaxes and moves back up into the chest cavity. The inner intercostal muscles contract, the air within the thoracic area is diminished. All these actions cause the pressure inside the thoracic cavity to increase, so air is expelled from the lungs or exhaled.
There is a symbiotic relationship between the interior thoracic cavity and the external atmospheric pressure. The body is able to maintain equilibrium and gas exchange by performing this action hundreds of times a day.
When you talk about equilibrium, are you referring to homeostasis?
Yes. Tell me what that is.
Maintaining a normal internal environment.
Right. Normal respirations maintain oxygen and carbon dioxide levels. They help keep our acid-base balance on track. Now, let's take this a step further. To understand how a pneumothorax would impact homeostasis, we have to define what it is.
A pneumothorax is a collection of air within the pleural space that typically causes a partial or complete collapse of the lung because of pressure change within the thoracic cavity. It can be a closed pneumothorax, which is a result of blunt trauma, or an open pneumothorax, which is associated with a chest wall defect, as from a stabbing or gunshot. In either case, air enters the cavity, causing an increase in pressure and collapse of the ipsilateral lung. In unusual cases, there might be a pneumo because of a bleb or little bubble that pops in the lung. This phenomenon is most common in tall, thin adolescent males. In addition, a lung can collapse as a result of fluid or blood entering the pleural space. For example, fluid may be present as a result of heart failure, from lymph fluid leaking into the space, which is called a chylothorax, from empyema or pus, which is associated with infection, or blood secondary to chest injury. This is called a hemothorax.
So in all of these cases, there's a change in pressure within the chest cavity, causing a break in homeostasis.
That's exactly right. Now, what signs and symptoms might you expect to see in a patient with a collapsed lung?
Respiratory symptoms such as decreased or absent breath sounds on the affected side, shortness of breath, cyanosis, hypoxia, and anxiety, probably pain.
Right. Also, there will be dullness on percussion of the chest wall and a decrease in blood pressure.
What about neck vein distension? I remember something about that. I know it can be seen in adults.
Right. But what about children?
Neck vein distension is not visible in infants and young children. They may also have no obvious decrease in lung sounds on the affected side, as the small size of the chest allows easier flow of sound from one side to the other.
Very nice. So you have to look carefully at those other signs. What about tracheal deviation?
It's a late and ominous sign, which may or may not be visible in infants and young children. In any case, it's an indication of a tension pneumothorax.
Is that bad? Definitely.
With a tension pneumothorax, there is increased pressure within the chest cavity that can build up with each breath, causing the ipsilateral lung to collapse. Eventually, the pressure will become high enough that the mediastinum is pushed toward the opposite hemithorax. This is called a mediastinal shift, and it can lead to kinking or compression of the vasculature entering the right atrium of the heart.
If the tension is not immediately relieved, hypoxia, hypercarbia, decreased cardiac output, metabolic acidosis, even cardiopulmonary arrest can follow.
Right. So how does chest tube placement work?
I know that air has entered the thoracic cavity, which disrupts the environment of negative pressure. Fluid in the pleura would do the same thing.
Right. Go on. So why is that so important?
The tube will help remove air or fluid to restore homeostasis. By removing the offending agent, the pressure is taken off the affected lung, so it can reinflate to its proper size. When that happens, pain and the work of breathing are decreased, and gas exchanges return to its pre-insult levels.
Tube placement to remove air is done at the lung apex because air is light and moves up, especially when the patient is in an upright or semi-upright position. On the other hand, a tube to remove fluids would be placed at the base of the lung because fluids are heavier, and with a patient in Fowler's or semi-Fowler's position, the fluids will make their way to the bottom of the lung. This can be done for chylothorax, pleural effusion, hemothorax, or even post-cardiac surgery to prevent buildup from blood and fluids that escape during the procedure. If the patient has a hemopneumo, he or she might need 2 chest tubes, one at the apex of the lung to rid the chest cavity of air, and another at the base to drain the fluids. Before this procedure can begin, it must be explained to the patient so he can get informed consent. After that has been accomplished, the team at the bedside must perform a timeout.
Okay, everybody stop. This is Charles Magnuson. We're placing a chest tube on the right side of the chest to reinflate the lung. Now, is everybody in agreement that we're placing a chest tube on the right side of Mr. Magnuson's chest?
Yes. Yes. We have just confirmed the correct patient and procedure. Right before the procedure, Rhonda will do a baseline assessment. At the same time, Jennifer is pre-medicating Mr. Magnuson for procedural pain. She is administering morphine sulfate, which will act as an analgesic as well as decrease the workload of the heart and breathing. During the procedure, she will be observing both Mr. Magnuson and the monitor. She will probably set the monitor to take vitals every 5 minutes. So she'll be looking for any significant changes. And by that, I mean a change of 20% or greater in blood pressure or heart rate, or a change of 5% or greater in pulse oximetry or respiratory rates. In addition, she'll be watching for any signs or symptoms of distress, such as pain behaviors, anxiety, restlessness, or changes in skin color. Dr. Jones has already explained the procedure to Mr. Magnuson. He has cleaned and draped the area, administered local anesthesia, and is going to place the chest tube in the intercostal space between the 4th and 5th ribs at the anterior axillary line.
The doctor will have Mr. Magnuson lift his right arm up over his head, pointing toward his left side to open up the intercostal spaces on that side. Dr. Jones will then use a scalpel to make an incision. Then, using his fingers or a hemostat, he will break through the fascia and push the tube into the thoracic cavity. When the tube is inserted, there should be a release of pressure, either from air escaping, like from this patient, or from the release of blood, fluid, or pus that built up in the thoracic cavity and was impeding oxygen exchange and lung expansion.
Okay, now that the tube is placed, what is important to us, and therefore the patient?
We need to put some kind of dressing on the insertion site.
Why? What kind?
We need to place a sterile dressing to prevent anything infectious from migrating to the thoracic cavity. The health can be very bad. And it needs to be occlusive so no more air can get into the chest cavity and deflate the lung again.
Nice. I like to use a petroleum jelly impregnated gauze first, covered by sterile gauze. After the dressing is secured, Rhonda will do vitals every 15 minutes times 4, or for an hour, or longer if she feels that Mr. Magnuson is still unstable. Then she will take vitals every 30 minutes for the next 1 to 2 hours. Then the vitals will be taken every 2 hours. In addition to vital signs, Rhonda will continue to monitor for pain, as well as the same signs and symptoms she was checking during the insertion procedure. What's next?
We need a post-placement chest x-ray first.
Very good. Jennifer has hooked up the drainage system.
Traditional chest drainage units, or wet suction, regulate the amount of suction by the height of water in the suction control chamber. It's important to note that it's the height of water, not the setting of the suction source, which actually limits the amount of suction transmitted to the pleural cavity. A suction pressure of -20 centimeters of water is commonly recommended for adults that do not have fragile lung tissue. For patients with friable lung tissue or infants and children, lower pressures will be ordered by the physician. There are also dry suction units. Instead of regulating the level of suction with a column of water, the dry suction units are controlled by a self-compensating regulator. A dial is utilized to determine and set the pressure. Typically, these units are preset at -20 centimeters of water, but can be adjusted to -10, -15, -20, -30, or -40 centimeters of water. Dry suction control systems have many advantages. First, higher suction pressure levels can be achieved for patients with large air leaks, poor lung compliance, or empyema. Furthermore, setup is easy. The absence of bubbling provides for quiet operation, and there is no fluid to evaporate, which would decrease the amount of suction applied to the patient.
Watch as Jennifer connects the chest tube to the drainage system and applies suction as ordered. She is making sure all connections are securely fastened and taped to prevent accidental disconnection.
And then,
Monitor the chest tube drainage hourly and report a significant increase or decrease to the physician. Record the time and corresponding fluid level on the collection chamber. If using the water seal system, check for bubbling in the water seal chamber. If you see continuous bubbling, air is leaking into the drainage system. Check all connections to make sure they're tight, and check the collection device for cracks. Don't forget, intermittent bubbles are expected in the water seal chamber when the patient has a closed pneumothorax. This is because air continues to escape from the lung's damaged surface. When the site of the air leak heals, you shouldn't see any air bubbles in the water seal chamber.
we also have to make sure the drainage tubing is free of kinks in the tubing, as they can cause a tension pneumothorax, which means air accumulates in the intrapleural space and can't escape.
Now don't forget, you can never clamp the tubing. That could also cause a tension pneumo. Also, you should be checking the patient's respiratory status every hour.
That means listening to breath sounds, asking the patient to speak, evaluating the work of breathing, and monitoring vital signs and pulse oximeter values, looking at neck vein distension, and checking the tubing and the system so it gives a decreased intrathoracic pressure.
You also need to assess for pain every hour, along with the vital signs, as it's considered the fifth vital sign. Then make sure that he is appropriately medicated. It's not uncommon for these patients to be anxious as well. The analgesics usually handle that, but if they don't, be an advocate for your patient and ask the physician for meds that are anxiety specific. They can go a long way in helping your patient feel better and have a better outcome.
Let's get Mr. Magnuson up to radiology for some scans. We'll need oxygen for transport, and we'll need to have him connected to a transport monitor.
No problem. I'm going to hang the collection chamber from the side of the bed below the level of the patient's chest so we can maintain good negative pressure.
Great, let's get going.
Okay, Mr. Magnuson, I just spoke with your doctor today. You're having your chest tube out.
Once the bubbling has completely stopped and there has been no more noticeable drainage, chest tubes can be removed.
Hey, Mr. Magnuson, remember me? I'm Dr. Jones. I'm here to remove your chest tube.
Hey, Doc, is this gonna hurt?
No, not really. I'm going to remove the dressing, and then I'll take the stitches out that hold the tube in place. Most people think that's the worst part because it can be a little bit you're in too much pain, then I can give you something for it.
Okay.
Now, I'm going to ask you to cough gently, and the tube will slide right out. After that, the nurse will apply another occlusive dressing, so no more air can get back into your chest.
Yeah, I don't want that to happen again. I've never been so scared in my life.
Okay, let's do it. Okay, give me a little cough. It usually takes 24 to 48 hours for the site to seal itself. Now, we'll keep monitoring you during that time to make sure you have no changes in your respiratory status. But that's just a precautionary matter. Then you'll be able to go home. But you'll need follow-up care for the insertion site to make sure it's healing properly. We'll help you arrange for that before you go home. You were very lucky. Lucky that was your only injury.
You're right, Doc. My new car's gonna have airbags. I've never driven without my seatbelt.
Okay, so see you in a few hours. Take care.
Before his discharge, Mr. Magnuson will be monitored for signs of respiratory distress that might suggest the return of the pneumothorax, such as shortness of breath, dyspnea, increased respiratory rate, decreased breath sounds on the affected side, and dullness upon percussion of the affected side. Fortunately, Mr. Magnuson doesn't experience any of these complications. After a few days, Mr. Magnuson is discharged to continue his recuperation at home with follow-up visits scheduled with his primary care physician. Placement of a chest tube can be a traumatic and anxiety-provoking experience, as it is often done emergently. Yet, providing care to these patients and managing their equipment should not be feared, as it's not performed any differently than that of any other patient. They need close monitoring to assess their physical and respiratory status, and frequent observations for potential complications, as some can have devastating, life-threatening results. In conclusion, nurses must use good